Greetings, we are Team 1. Today we'll be presenting the findings of our research, a comparative study of attitudes toward mental illness among young adults in India and Vietnam. Our members include
Vũ Thị Thu Yên, I'm from Vietnam.
I'm Lô Thị Thu Anh from Vietnam.
myself, Nicole Klepfer from the US,
Panral Sanjana Acharya from India.
My name is Sani Pradesh from India.
Before discussing the research, let us first understand some key points about the topic. What is mental illness? Mental illness is a mental, emotional, or behavioral disorder that leads to functional impairments that substantially interfere with major activities in one's life. What is an attitude? An attitude can be defined as a relatively enduring and general evaluation ranging from positive to negative. Stigma is a social construct influenced by culture that a group of people have in common, which is socially transmitted across generations. This construct around mental illness is a significant barrier when seeking treatment. Having open conversations about mental health helps shape perceptions of people with mental illnesses. Attitudes and beliefs toward mental illness are shaped by personal knowledge, cultural background, and by socio-demographic characteristics of the population. It's important to note that some studies show that demographic factors influence people's attitudes toward mental illness. Other studies show a weak link. Our study aims at understanding attitudes held toward mental illnesses by the specific countries and populations and contributes to the literature on attitudes toward mental illness, which can further be used to launch more informative initiatives to increase mental health literacy rates and reduce levels of stigma and negative attitudes within specific populations. To achieve this research, we investigated and compared the attitudes toward mental illness held by the young adult populations, specifically 18 to 25 years old, of university students in India and Vietnam by examining the role of sociocultural contexts in the development and maintenance of these attitudes.
Studies surrounding attitudes towards mental illness show the following. 197 million people, in other words, 1 in 7 people suffered from mental illnesses of varying severity in 2017. A 2018 study revealed that people show high awareness of mental illness along with high stigma. Out of 87% people showing awareness, 71% showed stigma. A follow-up study of 2021 showed an increase in conversation around mental health and improving attitudes. Hindering socioeconomic conditions prevent access to care and education, leading to stigma and discrimination in work. In theory, access to mental health resources and education should lower the stigma and improve attitudes towards mental illness. There are gaps in the implementation and enforcement of the Right of Persons with Disability Act of 2016 and the Mental Health Care Act of 2017. For example, many insurance companies exclude mental illnesses from full coverage. Further, there is a paucity of psychiatrists and mental health resources. The 2020 budget for mental health care was just 0.05% of the general healthcare budget. A fifth of young Vietnamese people experience mental health problems as per the WHO report. There is a high level of stigma and lack of awareness around mental illness. People with mental illness are often considered dangerous and abandoned by families. Even the Vietnamese word for psychiatrist translates to doctors who treat madness. Vietnamese culture strongly contributes to the negative attitudes as mental illness is considered something which will bring shame and lead to loss of face for the family. Research studying in this area is almost completely lacking. The mental health care legislation is weak due to the lack of explicit law on mental health. The National Mental Health Program only covers 30% of the country and very few mental illnesses. Psychiatric hospitals and social protection centers and community care providers receive very little funding and have a shortage of human resources. It is very important to continue studying the developments and attitudes of different populations towards mental illness and come up with better initiatives to improve the mental health literacy and rates of seeking professional treatment for mental illnesses.
We conducted our study in the following way. The study is a cross-sectional study. Due to time constraints, data collection was limited, and the sample size of 91 Indians and 55 Vietnamese who was obtained through convenience and snowball sampling based on the criteria of being an Indian Vietnamese national, Indian Vietnamese university student, and between the ages of 18 and 25 years. The scales were also translated into Vietnamese for greater accessibility to Vietnamese population. However, the validity and reliability of the translated scale was not tested. Each subscale consists of 10 statements, which are authoritarianism or disciplinarian attitude, benevolence or goodwill, social restrictiveness or social distance, and community mental health ideology or integration of care into community. Descriptive statistics, frequency analysis, independent sample t-test, and one-way analysis were used to compare attitudes based on each subscales and various social demographic factors, as well as tracking for significant differences in scores between India and Vietnam. With regards to ethical considerations, the study was done under the supervision and guidance of faculty from Amity University, Mumbai, Nha Trang University, and Evergreen State College. Ethical clearance was obtained in India from Human Ethics Committee of Amity. Informed consent of each participant was taken in the beginning of the form. A separate Google account was created to collect and store all the data, and personal identifiers of the participants were not used anywhere to maintain confidentiality.
It was found that young adult Indian university students overall have a more positive attitudes towards mental illness when compared to young adult Vietnamese university students in all subscales of the CAMIC. This could be attributed to cultural factors related to Confucian values and filial piety in Vietnam, as well as the lack of a mental health law compared to changing attitudes in India and relatively better institutional frameworks and policies with the Mental Health Care Act 2017. This slide shows the various demographic characteristics of the Indian and Vietnamese sample. In both India and Vietnam, significant differences were found in the following. Educational background, where postgraduate respondents have higher mean scores in CMHI, perhaps due to greater life exposure, formal and informal learning, and interaction with individuals from diverse backgrounds. It was also found in knowing anyone with a mental health concern, as it resulted in overall positive attitudes, possibly due to conversations around mental illness and raised levels of empathy and sensitization. In India, it was found in location, where semi-urban respondents have higher mean scores in benevolence, possibly due to a mix of positive collectivistic attitude and urbanization. In religion, where Sikh respondents have higher mean scores in authoritarianism, possibly due to carrying forward of traditional and conservative religious beliefs about the source of mental illness, such as homai or ego and karma or past sins. In previous study of psychology, with overall positive attitudes, perhaps due to access and exposure to accurate and reliable information regarding mental illness resulting in sensitive attitudes, and personal experience of mental illness resulting in overall positive attitudes. In Vietnam, it was found in gender, where females have higher mean scores in benevolence, possibly due to gender roles restricting them into kind, caring, and motherly roles, as well as the emotional distancing of men from feelings of kindness and empathy. And family structure. The respondents belonging to nuclear families have higher mean scores on benevolence, perhaps due to distance from traditional beliefs of stigma and filial piety compared to joint families, while still having positive collectivistic feelings. As a conclusion, the results of the research suggest that cultural values, education level, and contact with mental illness might play a vital role in influencing perceptions and attitudes held towards mental illness, as it is found to be common in both India and Vietnam. Understanding the cultural context and other social demographic variables surrounding an individual and population can be vital to uncovering the reasons behind stigma and thus implementing initiatives and strategies at grassroots, personal, and institutional levels to work on improving these attitudes.
Our study had some limitations. Due to time constraints, data collection was limited, resulting in a small sample size, which does not permit generalization of the research. Convenience and snowball sampling was used, which has led to low representativity of the sample. However, efforts were made to ensure diversity within the sample. The reliability and validity of Vietnamese translate CAMI scale was also not established. The study was cross-sectional in nature. A cultural relationship cannot be established between the social demographic factors and the attitude held towards mental illness. The entire study was quantitative in nature, hence making a qualitative understanding of how and why stigma and attitude toward mental illness develop in various populations. With regards to future research, this study can be used as a starting point to further understand attitudes toward mental illness by conducting longitudinal studies of a mixed model methods to track changes in the attitude and qualitative understand cause for stigma. Further research can be conducted to compare attitude health in Eastern and Western culture. Studies could also be conducted to compare attitude health between different age groups for a different development of better and more basic personalized initiative to reduce the levels of stigma across different subsets of a population. The process of working on this research paper was filled with ups and downs. Time zones and language barriers are still challenged to work together. However, we overcome this to the extent possible, such as coordinating work based on time zones and using simple language which is easily understood by all and matches the level of language. Further, conducting a research study with limits or no background in research grew to the challenging which was worked around by relying on each other's strengths and external faculty support. At the same time, we met new people and understood each other better. The presence of collaborative spirit amongst all of us helped in building a strong bond throughout this paper. All of us worked hard together and put forth our experience and knowledge for this research. This was also an opportunity for us to learn and understand more about the culture and perspective of India, Vietnam, and the USA. The most valuable experience throughout the research was that of interconnectedness. Despite cultural, linguistic, and other differences, we learn how to use our difference in a constructive way to work together and create something beautiful, not just from an academic perspective, but also from creative point of view. We support each other during difficult times and celebrate victories together, which is the essence of human spirit. Thank you for your listening.